seeing girls presenting typically around 13, 14 years of age who are slightly on the plumpish side, slightly obese, who have some hair growth which is there, they have some irregularity of periods, and because of the ultrasound they are showing that there's a multiple cyst on the ovary, they are labeled as polycystic ovarian syndrome. Everybody has got a capacity to store a certain amount of fat. If because of lifestyle measures or other factors the fat accumulation is more, this fat overspills and gets deposited in the liver, the spleen, the kidneys, and causes insulin resistance. This insulin resistance not only causes polycystic ovarian appearance and other features in the ovaries, it also causes other disorders like high blood pressure, liver disorder, diabetes, and cholesterol problems. Increase in testosterone levels disrupts the process of oocyte development, resulting in multiple small follicles, causing further production of androgens. So high androgen levels actually has a bad effect on the ovary. The diagnosis of polycystic ovarian syndrome in adolescents is challenging because many of the diagnostic criteria which are used in adults are also common in adolescents. So period irregularity is common, excessive hair growth is common, and the polycystic ovarian appearance is also common in adolescents. So unless and until an adolescent girl has a clear-cut proof of high androgen levels as suggested by a high Ferriman-Galway score or excessive hair or a high testosterone level and a proven problem in ovarian function in the form of period irregularities, we do not label them as a polycystic ovarian syndrome. Around puberty, it is common to have some hair growth, it's common to have irregular periods, and it's common to have a polycystic ovarian appearance. So we do not label any girl as PCOS till at least 2 years after the bleeding has started, 2 years after menarche. During pubertal periods, especially between 12 to 18 years of age, 20% of girls will have multiple cysts in the ovaries, and when they go to the radiologist, it is labeled as polycystic ovarian appearance. And this often results in a stamp which is given to them that they have a polycystic ovarian syndrome. What we need to understand is that polycystic ovarian syndrome is entirely different from polycystic ovarian appearance. There is no role of ultrasound identified polycystic ovarian appearance in the diagnosis of PCOS in young girls. The initial couple of years after the start of periods are the time when the ovaries and the hypothalamus, the pituitary is maturing. So often the periods may be irregular or anovulatory. If a girl has less than 4 periods in the first year, less than 6 periods in the first, second and third year, less than 8 in the 4th year, and less than 9 beyond that we get concerned with regards to irregularity of periods. Some girls with polycystic ovarian syndrome and hyperandrogenism may have excessive bleeding or may have more frequent bleeding because of the anovulation or problems in ovulation. Not infrequently, girls with PCOS may present to us with primary amenorrhea in that they never had period. Polycystic ovarian syndrome is a marker of insulin resistance. A girl with PCOS should not just be looked at from the angle of ovarian problem, from the angle of hair growth, but in terms of a holistic picture of whether she has other features like diabetes, cholesterol, blood sugar, liver disorder, sleep apnea, comprehensive metabolic evaluation in the form of an oral glucose tolerance test, liver function, sleep study, blood pressure have to be done in girls who come to us with quote-unquote polycystic ovarian appearance. There is a very limited role of ovarian or uterine ultrasound in the evaluation of polycystic ovarian syndrome. The main role could be in girls who have period irregularities to look at whether the endometrium is very thick, and in that regard they might need evaluation from a gynecologist.